Hey, have you ever been to the circus? Some of those contortionists are crazy talented. Oh, that's gotta hurt. Well, what you may not know is that some of these must-see attractions are actually persons with something called Ehlers Danlos Syndrome. And listen, I know what a lot of you are thinking. Ehlers Danlos, what? It's a group of genetic connective tissue disorders that can give individuals a leg up in certain parts of the athletic and entertainment industry. But today's guest is going to tell you why having a bendy body isn't always a good thing. Affecting thousands of people each year, this very misunderstood and underdiagnosed condition, which for many can take decades to actually get a formal diagnosis of, can bring about many symptoms from extremely stretchy skin to organ prolapses, heart failure, and more. You see, everyone with Ehlers Danlos is so different. That's what makes it so tricky to treat. But they do all have one thing in common. They all got problems with fascia. So what is fascia? Why is it important? And what is going on in these people with Ehlers Danlos that's causing their fascia to fall apart? We're gonna be talking to fellow bendy body, Dr. Linda Bluestein, an integrative pain medical physician and former ballet dancer herself, specializing in the treatment of hypermobility disorders, who on a weekly basis on her own Bendy Bodies podcast talks about the ups and downs of living with hypermobility disorder. So how can you better treat your fascia? Let's dive in. Thank you so much for being here. And as I said in the intro, you are an integrative pain medicine physician. You've been around the block. You've dealt with hypermobility disorders, Ehlers Danlos. And for the audience watching right now, maybe we can just start out by defining what is hypermobility, and then more specifically, what is the spectrum of this Ehlers Danlos syndrome that we see in the world?
So hypermobility simply means that at least one joint has greater than average range of motion. A person can be hypermobile in one joint or in many joints. It does matter how many, it does matter the distribution of the hypermobility. So somebody could be hypermobile in their hands and feet, for example, and that is a different clinical picture usually than somebody who's hypermobile in the larger joints or in pretty much most of their joints. So hypermobility itself is not a diagnosis. It's a descriptive term that, again, refers to the range of motion of the joint. There are a group of disorders that are abbreviated as HDCT, hereditary disorders of connective tissue, of which the most common is the Ehlers Danlos syndromes. And it gets pretty complicated pretty quickly. But if we think of the biggest bucket being hypermobility. And then within that bucket, we have symptomatic hypermobility, meaning that a person has hypermobility and they have symptoms that are likely attributed to the hypermobility. Within that category, Ehlers Danlos syndromes are one of the most common conditions. And we do believe that the most common type of Ehlers Danlos syndrome, the hypermobile type, is probably actually fairly prevalent. We don't have good prevalence data on this yet because that term was literally just redefined in 2017. So it'll be a little bit before we can get some really good data. But if you take all of these hypermobility disorders together, they're actually quite common.
Yeah, no, that's actually something that I had right over here on my notes. Next was just how prevalent, especially the hypermobile HEDS type, is within the community. We don't really have a good grasp on the accurate numbers for those. So I hope that some point in the near future we kind of do, because I feel like, as you know, it is a very misunderstood, dare I say underdiagnosed, but it's definitely misunderstood condition. I know I have a cousin and two cousins and an aunt who do have were diagnosed with hypermobility. Only one of them has been diagnosed with a more severe version of the hypermobility disorder, HEDS, and that's mostly likely from her father's side, of which I'm not connected. Though I do find it very fascinating because, like you said, the picture for all of these people with varying hypermobilities is drastically different at times. And that's what makes it so difficult to tackle the situation for the physicians and for everyone around that person, because there's no stereotypical picture. We have like the Brighton scale, which you can explain in a brief moment. Is that right? The Brighton scale, is that the?
So So yeah, there's the Brighton
Biden's
score and the
score,
Brighton
sorry.
criteria.
Okay.
So
I
it's
was
like,
halfway there.
could they, and then there's the Villefranche criteria, and now there's the 2017 criteria. So again, I try to focus on kind of the bigger concepts rather than
Right.
getting too caught up in the little
Minutia.
yeah, minutia, because even the Byton score, which is used very, very frequently,
Mhm.
and I don't know how many people will be watching this on video versus listening,
Yeah.
but the Byton score is the one that starts with, can you touch your thumb to your forearm? Can you bend back your fifth finger, or how far back can you bend it? And then when you straighten out your elbow, how far past straight does it go? How far past straight do your knees go? And then can you put your palms on the floor without bending your knees? And the challenging thing is that we generally lose joint mobility with age, but yet we tend to get more symptoms as we get older. So it can be very, very challenging. And you are 100% correct. These conditions are very, very, very much misdiagnosed, misunderstood. There is a high amount of what we call heterogeneity. So unlike some conditions that are pretty uniform across the board, if somebody has a certain condition, then they're going to look like other people with that condition. We know that these are very heterogeneous. People clinically will look quite different, which for the hypermobile EDS population makes it particularly challenging because that is a clinical diagnosis. We don't yet have the molecular marker for that to be diagnosed based on molecular genetic testing, unlike for the other 13 subtypes of EDS. So it is definitely tricky, but it's so important for physicians to be aware of these conditions, because once you know about them, you will start to realize that you have patients coming into your practice very, very frequently that are affected by these conditions. I think one of the big messages that medical schools, and I teach at a medical school, that we really should be doing a better job of getting across is that even rare conditions, like, you will see them. I think that so often we're taught, look for the horses, not the zebra. And so we think, oh, we're never going to see these, quote unquote zebra conditions, but we do. And those people really, really need our help. And especially if we add together like all the rare disorders, they're much more prevalent than I think most of us realize.
Yeah, I mean, when you look at the whatever the general statistics are out there right now, I think there's like something like it said something like 1 in 5,000 or something like that. Which, like, if you think about like the broad scheme of that, it's not like that's still pretty common in my eyes. Like 1 in 5,000 is not too many people. And when you think of rare, I think of like, oh, 1 in a million. But like 1 in 5,000 really isn't too bad. And I'm sure, like you said, with HEDS type, we're going to find that it's even more common. And we're going to know that it's a much more prevalent thing in our society. And maybe it's not as abnormal as we think. Like it is abnormal for being a what would you say is a normal human being, but it's so prevalent, is I guess my point. But I guess we could kind of talk about what are some of this is what I really want to talk about. Basically, when you look at all of these disorders on a broad spectrum, has to do with various types of collagen and collagen production and the quality of the collagen. And you did a great podcast. I forget who it was with, but it was on basically fascia and the importance of fascia. So maybe you could explain to the people that don't really know really how prevalent fascia is in our body, meaning everywhere, and why we need it. And in these EDS types, what is kind of going awry, and it's very different for each subtype. And even within one type, it can be different for each person.
Right, because even within a subtype, there can be more than one different molecular variant that's causing the person to have that subtype.
Mm-hmm.
So, and the number of subtypes has grown over the years. So who knows how many subtypes we're going to have, a few years from now. So that podcast interview on Bendy Bodies was with Jill Miller from Yoga Tune Up. And she has done lots of really fascinating research on fascia. And fascia is like a web that kind of connects different parts of the body together and encases our muscles and our it's this like a lot of people basically compare it to the casing of a sausage that connects all these different parts of the body. And the interesting thing that often happens when people have weak connective tissue is that some parts of the body might be loose, but other parts get overly tight in an effort to compensate for something being loose. So a great example is the shoulder and the scapula complex. So shoulders are something that are particularly problematic for people that have joint hypermobility. They can have a lot of laxity of their shoulder joint and instability, but they can end up having tightness, like in their pectoralis muscles, for example, because it's trying to compensate and stabilize that loose shoulder. And similar things can happen all over the body, but we can definitely get muscle tightness in different places trying to compensate. So that's where I was particularly fascinated by her work because she does a lot of work with self-mobilization techniques and doing self-mobilization, gentle self-massage and things like that can be very, very helpful for rebalancing the nervous system and for reconnecting with your body in a positive way. Because what happens when people are in pain is their nervous system can become sensitized, and so it can be painful to be touched. And so doing self massage and self manipulation can be, and when I say self manipulation, I don't mean like cracking your neck. I mean gently massaging your tissues and gently working with your tissues can help the nervous system reconnect in a positive way and can help with that central sensitization that can make the pain worse.
No, that's a really good tip, and I think that's something that I've seen like throughout the community. People find a lot of benefit from that type of incorporation into the life, self massage or certain kind of fascial techniques to kind of loosen up areas that are tight and or vice versa. Because it, like you said, it's such an individual problem. So I think it's important for everyone to really, I mean, like a lot of people say, you know your body best. And that's kind of what, when you're in this situation and you find out you have these sort of problems, that's kind of when you need to be vocal about the areas of your body that are affecting you, whether you're working with a physical therapist that knows this stuff or et cetera, because you can get them to help you improve those areas of your life. And I've seen in the community, some people make some really drastic improvements, and it's a lot of work. It's like
Yes.
a lot more work than the average person would have to put into their self-care routine. And so I think physical therapy is something that is very beneficial. So maybe we could talk about some of the things that you've seen with people that you've worked with, et cetera, that has been beneficial to kind of figuring out this fascial problem beyond just kind of self-massage, which is like really beneficial, I would say.
So I do want to touch on a couple of things that you said. So
Yeah, go for it.
yeah, I love that you said you know your body best. So you may or may not know, or audience may or may not know. So I have EDS. I have
Mhm.
hypermobile EDS. And as a physician for years and years and years, I kept saying to my doctor, something is wrong with me. I get injured very easily. I don't heal properly. And like most people, they kept saying, you're fine, you're fine. We don't see any evidence of anything until finally I saw someone who was more familiar and went through not just the Beighton score, but went through a lot of my other joints that are not included in the Beighton score and established the diagnosis. But so I think that's the first thing is I'm really glad that you pointed that out. You do know your body best. And it can be very, very frustrating to not be validated, to not be heard, and to go to healthcare professionals and feel like they are not really wanting to listen to you. I think that it's important, though, at the same time to recognize that, at least in the United States, our healthcare system is so incredibly flawed and so desperately needs work that if you're seeing someone, if you're a primary care provider, for example, which most of them don't know very much about these conditions, they have to know about
Mm,
such a broad range of things, of course.
yeah.
So if you are going to them and they are not willing to go down that diagnostic pathway with you, then I think the important thing is to say, okay, these are the symptoms that I'm experiencing. This is what most affects my quality of life. Can we work on this together? And because at the end of the day, I think if you really stress to your healthcare professionals that you want to feel better, you want to function at a higher level, that then they're more motivated to help you than if they feel like you just want a label or,
Yes.
yes.
Yes. Can I add to that? Because I think a lot of people go down this, and I've done this too with my own past ailments, and like I have an eating disorder history, and like that's kind of how this podcast came about, and that causes a lot of connective tissue damage as well in many facets. But I think a lot of people go through when they're dealing with these problems that they don't understand. They don't have a name for it. They're having symptoms, but their doctors aren't finding anything. All the blood tests are normal. All the imagings are normal, which is very common in EDS, especially when you're like your back or your joints are going all over the place and they stick you in a static position up an MRI machine. MRI is normal because you're not putting any strained show movement in there. So that's something to think about as well. But I think we often do go chasing after labels. And while I do think having an accurate prognosis and diagnosis is important to a treatment plan on some degree, like we've talked about earlier in the podcast, that because this is so individual, sometimes it's better to kind of go after what am I actually experiencing now, because there's no like silver bullet for any of these problems for anybody specifically. Everybody's silver bullet's going to be quite different. So I think really focusing on the things you can do for what you're experiencing versus just trying to get the label is more imperative and will better suit the patient. Because I think mentally too, after they get the diagnosis, sometimes I know people that will shut down after that and just kind of be like, oh, that's it. This is it. I'm just going to do nothing and let things go their course. Because it's very daunting when you get a diagnosis of a rare condition or a rare condition, as we see. And so I think it is important to motivate the patient as much as possible and motivate yourself to that degree. But I'll let you pick up where we just were. I just wanted to mention that. It was on my mind.
Absolutely. And that being said, for me as a specialist with dealing with this patient population, I know that how important the diagnosis is and how much it can help. But you're absolutely right. Yeah. It's all in your mindset of, if I have that diagnosis, do I have access to more physical therapy sessions? Do I have access to specialists? Do I have more validation from my family? And those kinds of things. So yes, it's absolutely all in how you use it and how you approach things and how you take that information and move forward. So definitely, because you're right, it is a lot of work for sure.
Yeah.
So speaking of work, so physical therapy, I think, is one of the absolute most important things for people that have Ehlers Danlos syndromes or any other hypermobility disorder. It can be hugely beneficial because we can do movements, the same movement using different muscle groups. And we often don't realize that we are doing movements in a dysfunctional way and a suboptimal way for our joints. So we can be causing damage to our joints, or we can be, causing more trauma, micro trauma to our joints than we need to be if we aren't working with somebody skilled in helping us with whatever problem it is that we're dealing with at the time. So, for example, right now I'm in physical therapy myself for my shoulder pain, neck pain, and not too long ago it was for my hip. So I'm working with the same physical therapist. She's absolutely amazing. She really helped me make a lot of progress with my hip, and now she's helping me make a lot of progress with my shoulder. Now, I think part of the important thing with physical therapy is to understand that at the end of the day, I have to do the work. She's not going to do the work for me. She can't do the work for me. She can prescribe the treatment plan, but if I don't do the home program, then it's it's not going to happen. I'm not going to get the results. The other thing is having realistic expectations. So I'm going to be really disappointed if I think that doing physical therapy is going to take away all my pain and or, give me my body back that I had, 20 years ago. So at this point in my life, I have a pretty good idea of what I can achieve with physical therapy. Of course, I know, the things that I need to do with my nutrition and supplements and medications and all of those other things. So it's a comprehensive treatment plan that I prescribe for people when I am treating them as a patient, and it's so important to look at all of the various different aspects that affect a person's pain and affects their other symptoms that they might be having related to these conditions.
Yeah, no, I mean, that's very, I mean, this is such a nuanced topic because there's so many different uh, specificities for people. But I think physical therapy is definitely like one of those things that's imperative, I would say. I'd say anyone that is suffering from a hypermobility type problem should be doing it. I'm in physical therapy. I'm going through like a diagnostic stage of figuring out if I have any of those sub issues or if it's more related to long time eating disorder tendencies and overexercise. Because I mean, all of those things also, by the way, can overlap. so,
Right.
so, so I think I want to talk like diet and supplementation with you in a moment too, because I know that is a big part of what you do with clients because it's just for general life health, anyways. It's important. But and that makes it even more important for somebody that has another thing going on. They kind of got to be on their toes for everything. Again, definitely not a silver bullet. It's not gonna turn you back to like a normal human being at all overnight. But anything that can improve your quality of life, I think is worth investigating. So maybe we can kind of just start with, I know I've seen you do some interviews with Dr. Terry Walls on her thing, and she's famous for the Walls Protocol, which I've talked about in the podcast several times in the past. But maybe you can talk about kind of sort of what a kind of day in the life of going through some client work would kind of be like and addressing problems, because it's going to be different for everyone. So just kind of a general basis.
Definitely. So when I'm working with clients or patients, it depends on what part of the world that they live in terms of what I am able to prescribe and do for people. But I really want to look and see where are they starting from, because someone who is starting, and I have a lot of intake paperwork that I ask people to fill out because of the fact that people are so dramatically different from each other. So, and one of the things that I have them fill out is a nutrition questionnaire, and I want to see what they're currently eating. And that makes a huge difference in terms of what I'm going to recommend that they do, nutrition wise. And, we have to work with the limitations that people have. Some people can afford to go to Whole Foods and buy organic produce, and other people, they can't afford that. So you have to really customize the program to work with that individual person. So then we might say, okay, well, let's see what we can figure out with, frozen produce or something like that. And I try to focus on what to eat and not just what to not eat, especially because I work a lot with dancers and gymnasts, circus performers, skaters, other people who are at high risk for eating disorders. Many of them have had eating disorders, or are disordered eating patterns. And so we want to be very, very careful not to make that worse, or maybe they are doing really well from that standpoint. We don't want to bring those issues back up, which can be challenging because one of the things that I sometimes do recommend is like a elimination diet type of process, really for the purpose of seeing what things are you eating that could be potentially contributing to your symptoms. And if you kind of clean things up quite a bit, it can help to establish those patterns. It can be hard to figure that out when there's so many different variables that are impacting a person's symptoms. So nutrition, though, is a very, very important place to start from, because I say all the time, no amount of supplementation is going to make up for a poor diet. So if someone is consuming a lot of sugar, for example, then we look at, well, why? Why are they craving sugar? What's going on that they're eating so much sugar? And, how can we reduce those cravings? How can we, what can we do with medications or supplements also to try to kind of help together create a more beneficial chemical milieu in the body? Because the body needs that substrate. The body needs minerals and nutrients in order to build connective tissue. And even if you have a connective tissue defect, genetic connective tissue defect, it still matters a lot what you eat. So I'm really glad that you pointed out that with eating disorders and other variables, what can end up happening is we can end up with a picture that looks like hypermobile EDS, but it may be they haven't found the genetic marker yet, because so many of us, we look like we have hypermobile EDS, but we all look like that for a different reason. Or maybe not all, of course, but like maybe this group has it for this reason and this group has it for another reason. And there's so many different reasons mixed in together that it's been difficult to find the actual genetic basis, because other things like um, nutrition matters, environmental factors matter. Has a person been exposed to mold, for example? Have they had a tick-borne illness? Are they exposed to different toxins in the environment? Did they have a lot of adverse childhood experiences? All of those things impact how your body functions and impact your outcomes.
I think that is a very important statement to make, because I feel like in the general like medical community, most of that of what you said is not even a thought. As far as I mean, nutrition might be a thought, but it's on a very kind of blanketed like basis. It's not very in depth. I mean, as you know, going through probably medical school, I'm not sure how much nutritional training you had, but I've heard it's not a lot. If and yeah,
Zero.
exactly. So I never bring up nutrition with my doctors usually, just because I kind of know what they're going to say, or more likely lack of saying. But nutrition, I would say, I mean, it's important with these types of things to think of the things that you have within your control, and things like exposures and what you put in your mouth, how you move your body. These are things that you do have control over and can make a positive or negative impact on your overall well-being. Because I think it's all about giving back. Like I said before, it's empowering the patient. So I always like to think, and I love that Terry Walls is kind of a big advocate for this, is that we have more control over a lot of these aspects than we think we do. Our genes are one thing, and our genes affect us more in some people than other people. In EDS, they affect us a lot more than somebody with some other ailment. But you do have an ability to address the factors that can play into those genetic things even more than otherwise. And one of these things I wanted to talk about too with you before we get into mental health, which I think is going to be an interesting topic, because that's a huge thing with anybody that deals with chronic illness or chronic pain. But I want to talk about, there's a lot of sort of related associated ailments with Ehlers Danlos. There's POTS, for instance, postural orthostatic I can almost get it all the time. I know what it stands for. It's just like the pronunciation gets me every time. But there's POTS, and mast cell activation syndrome is pretty common. Histamine intolerance that goes along with that. So maybe you could talk about just kind of an overview of some of those, and kind of at least the more prevalent things you see with people that you've worked with, and kind of what things you kind of look at to help them.
Sure. So in my practice, the amount of overlap between the population that has hypermobile EDS, or they may not quite exactly meet the criteria for hypermobile EDS, so they would fall more into the hypermobility spectrum disorder category. So whichever diagnosis you have, or another type of EDS actually could be also. But there's a very, very high degree of overlap between those conditions and dysautonomia. And dysautonomia is, again, if we think about things in more general terms, that's a basket of conditions that relates to the autonomic nervous system, functioning of the autonomic nervous system. So we have the parasympathetic nervous system and the sympathetic nervous system, and they are supposed to be in balance with each other. The sympathetic nervous system is the fight, flight, or freeze, and the parasympathetic nervous system is rest, digest, and restore. And POTS is a subtype of dysautonomia, and that does stand for postural orthostatic tachycardia syndrome. And so when people have POTS, they have difficulty with being upright. Their heart rate goes up by, depending on age, more than 30 or 40 beats per minute when they go from laying down to standing up within 10 minutes. And it has to be, those symptoms have to be present for more than 6 months. Those are the current diagnostic criteria. So we know that people who have POTS have difficulty with upright posture. Anxiety is a very, very common condition that occurs with POTS and also occurs with hypermobile EDS. But we also know that there are certain abnormalities in the brain that are more common with people that have hypermobility and hypermobility disorders, like, for example, the amygdala, which is the fear center of the brain, is larger. We also know that the heart rate variability that can occur with the dysautonomia syndromes can also induce anxiety. And so it can be very tricky to tease all of that out. And anxiety can definitely play a really significant role with chronic pain. And then mast cell activation syndrome is also, interestingly enough, so mast cells are present where we interface with the environment. So they're in the gastrointestinal tract, they're in the genitourinary tract, the respiratory tract, on our skin, places like that. And mast cells will respond normally under certain sets of circumstances. But if you have mast cell activation syndrome, your mast cells are kind of trigger happy. They respond more easily than they should. And so, interestingly enough, anxiety is a trigger for mast cell release, mast cell degranulation. And so it can be this really challenging triad of symptoms or triad of conditions. And there are a couple more that are kind of an extension of that, which one of which is gastrointestinal problems, and the other one is autoimmune disorders. But the interesting thing is gastrointestinal problems are also really strongly prevalent in mast cell activation syndrome and in dysautonomia, because the autonomic nervous system controls the GI tract. So it can be hard to tease out, like, does this person have a separate GI problem, or is their GI problem directly a cause of their dysautonomia? So teasing out what all is going on with an individual person is really, really important. And if they're having gastrointestinal issues, what do we think is the underlying reason? And getting back to what we were talking about earlier with more traditional medicine. So the way I think of it is, with an iceberg, right? We see just a little tiny bit above the surface. And then there's this massive amount of ice under the surface. Traditional medicine focuses on what's above the surface. And we're just playing whack-a-mole, and we're just, because we have 7-minute visits, and sometimes less, we're just trying to get people, slap a Band-Aid on it and get them back out of the office. But we're not addressing the root cause of the problem. We're not looking, they don't have time. They don't have time to look at nutrition and what psychosocial variables could be impacting the person's symptoms, what movement patterns could be addressing their symptoms, or even getting a referral for those things to be addressed. There just isn't the time, because this is a very time-consuming process. How did all of this get raveled up, and then how do we unravel it so that things start to be cleaner and the person starts to feel better and function better and all of that? It is not something that's quick, as you pointed out, and we want to make sure that we have realistic expectations. But people really can make remarkable progress if they're willing to do the work, if they're willing to put in the time, and be patient with themselves and and with their providers, so.
Yeah, I mean, that's why I'm so thankful to have people like you in the space that are really kind of making this information available and like physically being there for people that are going through this, because I feel like so many people get discouraged. And I have a good friend who's going to be another guest on the podcast who doesn't have Ehlers Danlos, but is on the hypermobility spectrum, really bad, 30 years of her life, no real diagnosis, terrible pain, so much pain that you touched her, she would hurt because of all the fascial tightness and disalignments and all these things. Just dislocations all the time, couldn't walk, was like bedridden, diet was horrible. And over the last, I believe, 3 years since I've known her, she's made this remarkable turnaround in her life because she finally found some people that were willing to take the time with her. And she's put in the work. And the most important part is she's put in the work every single day to mind her fascia, mind her bendy body, and has made some real crazy improvements. I'm truly like impressed. So it is possible to make improvement, but like you said, it's really how much time and effort are you willing to put into it. And some people also, I don't want to say it's just like this thing where people don't willingly want to do it. I mean, some people just are not in a financial position to do certain things. They're not in they have kids and they have to work full time as well on top of having this type of disorder. So it's a very tricky thing. I mean, it's really difficult. So I think it's important though to just do what you can do and focus on those things. I don't know if you have anything to add to that.
Definitely. So I think it's also important to note that you can do everything right and still not be doing well.
Yep.
So if you do everything, when I say everything right, everything for your body that's going to help make things better. Some people have the genetics that really are just against them, and or they've had injuries and a variety of things happen that that they really have a lot of problems. So I think it's really important anytime we are having a more in-depth conversation like this, that we don't make people feel guilty if they're not doing well, because while most people can make significant improvement, not everyone is going to have the same outcome for sure. And it's like whenever we talk about nutrition and cancer, we want to be really careful not to imply that if you got cancer, you must not have eaten well.
Yeah.
And so I think it's important to empower people, but at the same time, like not make them feel guilty.
What sort of improvements have you seen with people that you've worked with, as far as like coming from kind of really crappy situations and then doing well over time? What things have you seen?
So I've seen some really fascinating things, to be honest, including people that came to me in wheelchairs and are now walking.
Wow.
And oftentimes it's not like they needed to see me for multiple visits. I don't work within the healthcare insurance based
Mhm.
system, because my visits are too long and insurance doesn't value that. So, they're reimbursing practices that are seeing, 30 and 40 patients a day. But you can't cover your expenses when you can only see a handful
Yeah.
of patients a day. You truly can't. So so I don't accept insurance payments. I give people the paperwork to submit to their insurance. So, but oftentimes I can see somebody once or twice, and by making the diagnosis or by giving them like a treatment plan that I outline, and then they kind of take it and run with it. If they can't, if they can't really afford to come back. But I've had people who, they came to me, they were in a wheelchair. We talked through things. I made some referrals. I know I'm thinking of one person in particular who was labeled as having conversion disorder. And this is a young girl, 16-year-old
Oh,
female.
wow.
She was labeled as having conversion disorder. She was sent to a psychiatrist, and they didn't do anything else for her. And I saw her and was extremely concerned that there were things going on physically that they were missing. And so referred her for, some more extensive workup. and testing and evaluation. And I saw her, maybe it was a year or so later. And, she walked up to me and thanked me and hugged me. And this is pre-COVID. So it's, I've had some very, very dramatic results, not always ones that I've worked with super closely, because like in this person's case, all they needed was for me to, kind of jumpstart the process, and then they were able to take it from there. So, and then in other cases, it was, really a matter of working on making changes to the diet and other, lifestyle type things that they were able to do. And, then I hear back that they're doing, remarkably better, or I've seen them for a number of visits, and they're, each time I kind of ask, I don't like the pain score numbers. I really hate those numbers, to be honest,
Yeah.
because I know for me, like at one point I was having a lot of problems with my wrist, and it turned out I had a huge cyst inside a bone in my wrist, and they kept thinking I had carpal tunnel. And they would ask me, well, what's the number? It's like, well, the number is like right now a 0, but I can't open a door. so,
Right.
so it's really about function. It's, so I try to really focus on, for my patients, what are the functional limitations that they're experiencing, and how can I help them be able to do those things? I mean, you have to be able to open a door, and especially if there's something that can be fixed, something that can be improved. So finally someone took an x-ray and they're like, oh, look, you have a huge hole in your bone, you know.
It's wild. It's wild.
Assumptions are really dangerous.
Yeah. Yeah, no, I mean, I've gone through similar things where I've been experiencing for about a year and a half these kind of neurological things that kind of started as carpal tunnel type feeling, and then eventually spread to like whole body stuff. And I'd like something that's important is, like we mentioned environment earlier. I had been living under chronic stress physically
Mhm.
and mentally for several years. I was still, even though I had weight restored from my eating disorder, I was still behaving in overexercise. My cortisol was all spiked. As I recently found out, all of my hormones, all of them, are just crashed. Testosterone's like 0. I've basically been redesignated as a female, but all of these things that were kind of compounding dominoes that ended up in where I am at now. And so I was eventually diagnosed with something called small fiber neuropathy, which is
Ah,
also common in Ehlers Danlos
yep,
syndrome.
it sure
Because,
is.
but I actually wanted to ask you, with small fiber neuropathy and Ehlers Danlos, do they associate? And they probably don't know a ton on it because it's still pretty young science as far as small fiber. But is it related to the fascia around those nerves, or what are they seeing, or is there anything you know more that I don't about that in particular? Because I just know so many people have it.
Right. So I'm glad that you mentioned small fiber neuropathy, and there was something that you mentioned before that I wanted to touch on.
Was it the
Oh,
compounding
the
stress?
hormones. The
Oh,
hormones.
hormones.
I'm really glad that you mentioned hormones, because I don't think most people realize that hormones are produced by bacteria in the gut,
Mhm.
and that the hormone levels that we have in our body influence how much pain we have. So if we have lower testosterone, for example, and you're absolutely right, females have testosterone and males have testosterone.
Yeah.
And in general, testosterone, especially in males, goes down with age. And so it can be very, very important to optimize our testosterone level, because that also helps to build muscle mass, which protects our
Yes.
joints. And so if we have low testosterone, that can definitely influence how much pain we have. So again, it comes back to the nutrition. It comes back to, general wellness and physical activity. So if we don't move our body and exercise our muscles, then our testosterone level will go down, which makes it
Mhm.
harder to build muscle mass, which puts more strain on the joints. So it's kind of a vicious cycle, and the
Yeah.
hormones affect so many different parts of our body. They affect our mental well-being. They affect our ability to function physically, and all of these different things. So basically, we have different. So getting back to the small fiber neuropathy, yes, this is extremely common in people that have Ehlers Danlos syndromes and related disorders, and is a frequent cause of chronic pain. and often causes pain in what's called a stocking glove distribution. So like in the hands and the feet, like basically in the feet, kind of like socks, and in the hands, kind of like gloves. And there's different ways that we can test for this. We can test for it doing what's called 2-point discrimination, seeing how well you can discriminate two things touching versus one. And that gives us an idea of how well those small fibers are functioning, and also doing the skin biopsy. So those are a couple of ways that we can assess for this. Small fiber neuropathy is definitely something that, from the standpoint of chronic pain, definitely is a very important variable. And you mentioned earlier about somebody having the word for it would be hyperalgesia or allodynia. You mentioned that your friend being
Couldn't be touched. Yeah, super
yes,
sensitive.
yes. So again, even for me as a physician, I'm an anesthesiologist. So, and I had a pain clinic when I first finished my my residency, and I did a pain clinic and OR for a few years, and then moved to where I live now in Wausau, Wisconsin, and they didn't need anyone to do pain clinic. So I didn't do pain clinic for a number of years. But I kind of forgot about, if I ever even learned it, about how the nervous system gets sensitized and how people can develop what's called hyperalgesia and allodynia. And hyperalgesia is where things that are normally a little bit painful are a lot painful. So if you pinch someone whose nervous system is sensitized, instead of it being slightly painful, it's going to be really, really painful. And allodynia is where something that is normally not painful at all causes pain. So, again, I think once people understand that there are words for these there's actual medical terms for these things. It's unfortunate because your average physician is under so much stress. Speaking of stress, they are under so many demands for their time, and I work with medical students all the time, and trust me, I have never met a medical student that wasn't compassionate, empathetic. They're going into it for the right reasons, but oftentimes after they've been practicing for a while, they are just burnt out because they're being told by their employer, you have to see more and more and more patients. You have to be, doing less of this, that, and the other thing. I have a good friend who is in an insurance-based system, and she has shared with me that her employer has told her she cannot accept any more EDS patients. In fact, she needs to get rid of some of them because they're too time consuming. So it's important for people to understand the constraints of our healthcare system, and that anything that they can possibly do to work with other people in the community, working together to try to improve healthcare, because healthcare right now, it is designed for the acute problem that you go in, you get a fix, and it's best if it's a procedure or surgery, because those are the most highly compensated. Insurance companies will reimburse the most for those. And so those are the kind, you go in, you've got a broken arm, you get it casted, you're off on your merry way, plus or minus if you have to go back in to have it, surgically fixed or whatever. But that's what our healthcare system is designed for, not for multi-systemic problems that are, going to be requiring, lifelong management.
Yeah, I mean, I think that's kind of the major issue with the medical system. I'm glad you brought up too that, like, and I mentioned this actually in the previous podcast that we just recorded the other day with the dietitian. We were talking about the healthcare system and how it's just not, they don't have any knowledge on diet, and sometimes the dietary guidelines themselves are flawed. And we were talking about all these people that are going into these areas of work, generally almost always have great intention of helping people and wanting to do good, but they enter a system that's kind of built against maybe what their mission originally was to go in. It's in an insurance-based system. It's really a lot of pressure on these doctors to see as many people as they can a day. You end up waiting 6 months to see an endocrinologist. You see him for 10 minutes and you leave there not learning anything. And I've been there, and a lot of us have been there. So that's why I think it's important to find people like yourself. And I mean, it's unfortunate because a lot of people are also relying on their insurance to pay for all of these things. But it's like the time required in an insurance-based system just doesn't allow for that. So that's just kind of where we're at. But I'd kind of like to round this podcast off, at least this first one. I'd love to do a follow-up on some more of the minutia, like mast cell, because I find it so fascinating. We could talk about it all day long, really. But kind of just for anyone out there that's maybe experiencing these problems or already has a diagnosis of hypermobility or EDS specifically, what are some things that you would recommend that they do like right now to start taking action on a broad sense, just because it is so variable?
Right. And of course I can definitely make, I can definitely share some things that are generally helpful, but of course for any one individual person, until I see people one-on-one, like it's hard, I don't know what that person needs. Right.
Of course.
But I can make general suggestions. So the things that I have found to be most important for people, number one is keeping an open mind. The people that have made the most progress come in with an open mind. And like we said earlier, they're willing to do the work. And because there are people that, still, even when they come to see me, they've got their mind made up. They want a specific thing. That's all they want. And, I'm required to prescribe for you what you need medically, not necessarily what you want.
Mm-hmm.
So I need to provide for you what you need, not what you want. So, there are some people who think that opioids are going to be the right thing for them. And while they can be appropriate in certain circumstances, and I think that the opioid crisis has been so incredibly detrimental for people with chronic pain, because the people who need them can't get them. And yet there's people who I think have them that could be better served by other things. So it's really, it's a huge mess right now. But opioids are also a problem with mast cell activation syndrome, because they can cause mast cell degranulation and release of mast cell mediators. So that's one thing that can be really important, is keeping an open mind, going into your visit with any of your providers, whether it's your physical therapist, your physician, meeting with a nutritionist. I work with one nutritionist the most, and her name is Kristen Koskinen. And on Instagram, she's at Eat Well Pros. Or no, she's at Kristen Koskinen, Kristen-Koskinen-RDN. She and I have a lot of patients in common. She's really fabulous. And then if you go in to see her or me or a physical therapist, and you have in your mind, this is what I want, this is what's going to work, and you're not open-minded, then you're probably not going to get the best results. I'll have patients that I'll recommend that they go to physical therapy. I already tried that. It didn't work. And it's like dating, right? Whether it's a psychologist, another type of counselor, a physical therapist, a Pilates instructor, a nutritionist, any of these resources that you may be using, you may or may not have a good fit with that person. So maybe you're going to need to go to a second person and see if you have a better fit with them.
Yeah.
And I can relate to people who say, well, I did physical therapy and they hurt me. They made me worse, because I have had that happen to me. And I have gone to doctors. I went to see a DO, a very, very young DO. And oh man, he cranked on me so hard. I was in so much pain. But I went back to him and gave him that follow-up information that, by the way, so that he would know. So keep an open mind. Try not to be overly judgmental on yourself or other people, because I think that's the other problem that people run into. They come into encounters with, sometimes with so much judgment already formed. And so I think that can be, both against themselves and other providers. So I think that can be another important thing that we can do. Also, another thing that I often suggest to people is you want to try to bring the joy back into your life. So that's going to be different for different people. For some people, it's painting. For other people, it's dance. For other people, it's reading a book. But whatever brought you joy before you had your pain problem, try to identify that. Try to bring it back into your life. Sometimes pain is there to get our attention, right? But sometimes when we've been in pain for so long, we kind of forget the other aspects of ourselves. And we can get so wrapped up in our pain. My son actually said to me once, and it's funny how certain things stand out in your mind. I
Yeah.
can't remember how old he was at the time. I think he was probably like 11. No, he would be a little older than that because my problems really got bad about 10 years ago. And he said so he would have been 14. And he said to me, "Mom, do you realize how quickly after you meet someone that you tell them about your pain problems?" And that was like, wow, that is not what I want. That's not the example I want to set for my kids. So that was a pretty profound thing that he said to me, and really made me realize I need to rewrite my own story and make my life be about a lot more than just these challenges that I'm experiencing right now. It can be hard when we're in the heat
Mhm.
of it not to see, any of the other aspects or see the possibilities. It can be really, really hard when we're in pain and everything hurts. It hurts to move, it hurts to eat. Our heart's racing, we feel anxious, we feel depressed. It can be so incredibly hard to see that there's any possibility of any other way of living. But so much of it starts up here.
Yeah, no, I would agree. And you'll just probably say this is right. I think you already did with some of your clients. You see the most results, even physically, with clients who come in with an open mind and are already prepared to do the work here, but also in here, because I think the work in here, well, it affects all the rest of the work. I mean, your thoughts and stress affect your microbiome and all these other things that are imperative of your hormones, your cortisol spikes, all these things. So I think that really, I do think it's important. I hate because I hate to tell people like people hate being told like, oh, it's in your head kind of thing. But there is this aspect of chronic pain that is in your head, because I don't know anyone that doesn't feel worse when they're really bad in here mentally.
Right.
And so to some extent, hey, I hate when doctors say, oh, you're probably just stressed and all this. I hate it. But it's true. I mean, like, we are really stressed. So there is that aspect of that to healing. And I think it's really important to take into account.
And I think a good way to think about it is, when we talk about the mind-body connection,
Mm-hmm.
I think that we really need to start thinking of the mind and the body as being all one and the same. I think that rather than thinking of the connection, like, of course they're connected. Everything that happens in the mind affects the body, and everything that's in the body affects the mind. And the way that I like to say it succinctly is it is physiologic, not psychiatric.
Yeah.
So our thoughts affect, exactly like you said, about the cortisol release and all of these other things, and that makes the heart rate go up, and that makes us feel more anxious, and it's natural. I mean, again, pain is there to tell the body, hey, there's a problem, But again, all pain signals, whether they're physical or psychological or any of that, it's all processed up here. That is where we process pain. So yes, it often starts in the tissues, but where we sense it is up here. So it's the other aspect of that I think is so important is the sooner that you start doing better things than the things that you have been doing that maybe or have caused you to fall down the EDS spiral or the EDS rabbit hole, I like to call it.
Mm-hmm.
The sooner that you start doing the things that will help you dig your way out, the better. Because the longer that goes on, the more the sequelae that happen. And we know from functional MRI studies that when a person has pain for longer and longer, the parts of the brain that connect, that amplify pain signals, they get stronger, and the parts of the brain that dampen pain signals get weaker. So we want to intervene at the earliest possible time. And people will sometimes reach out to me and they'll say, is it too soon? I say, it's never too soon.
Mm-hmm.
And I'm a huge believer in not over medicalizing. So, excuse me, sometimes, I've seen very, very young people, very, very young. And I just give the family information and I give the patient information. And I say, okay, here's some things that you can do. And oftentimes it's a one and done, here's some things that you can do. And then going forward, you just kind of, see what happens. And I'll let them know if I think I have a high index of suspicion for a connective tissue disorder or a low index of suspicion. But it's so important to not wait, because in general, if you're already in that spiral, and I've been in that spiral, and I know it is bad. It is really bad. It is really hard to dig your way out. I've been in some pretty low places. I get it. Everything hurts. It's a mess.
I've been there too.
Yeah. It's really, really hard. So I think that that's the other important thing, is that the earliest you can do that, the better. Because I have a lot of people who it's so fascinating. I have a lot of like teenage patients that are brought in by their parents, and it's great because in many cases they haven't been in trouble for that long, although sometimes they already have been having problems for many years. We are able to often do things for our kids that we aren't able to do for ourselves. So I think that a lot of times parents, they're willing to bring their kids, but they're not as willing to, spend the money to get help for themselves and that kind of thing. And I get it. I'm a mom. I've done things for my own kids that I haven't done for myself. So I understand that. I understand that mentality, but that's where the insurance part of it makes me absolutely crazy, because I wish insurance companies would recognize that, you can come and see me now so you don't have to see me later. Come and see me now. We can work on doing some things better. And maybe you can avoid some of those surgeries and procedures and expensive things, and then not being able to work and things like that. Yeah.
Yeah, no, I think that's great. So where can people find you and reach out to you and all that good stuff?
So I'm on a lot of different social media platforms. I'm probably most active on Instagram and Twitter, Facebook. I'm also on LinkedIn, although I'm not as active on there as I probably should be. But all of those are at Hypermobility MD. And my podcast is at bendy_bodies. I host that with Jennifer Milner, who is a wonderful Pilates instructor who works a lot with hypermobile dancers. And she and I host the Bendy Bodies podcast together. And so you can find her also. And you can go to my website, hypermobilitymd.com, for more information, services, booking a workshop. I love to speak to groups and provide information to them as well.
I love it. I love it. I'll have all those things down in the description below for people. And I really appreciate the work you're doing, and really keep it up. It's really inspiring.